So let us begin our descent down the GI tract here. We'll start where it should start, in the mouth, and we'll work our way to the very end. So we are dividing this up into the upper gastrointestinal tract and the lower GI tract. And the upper GI tract is the mouth, pharynx, the esophagus, and the stomach. Everything else is the lower. So we can get a lower GI, that's what they're looking at. The rectum, the large intestine, the small intestine. When you do an upper GI, they're looking at everything from the stomach on up. It all begins in the mouth with mechanical and chemical digestion. Okay. Mechanical digestion, teeth. Chemical digestion with salivary amylase, some lingual lipase, but this is the actual enzyme that actually does something in the mouth. So there's your chemical digestion. Pharynx is involved in basically just moving what is called a bolus of food at this point, not food, bolus. It is in charge of moving the bolus down. Esophagus, the same thing. Mucus is what helps to do that. And then the stomach is where we have a bunch of magic happening. This is where that bolus of food gets mixed, gets churned up mechanically, gets enacted upon chemically, and it gets broken down to what's called chyme after that. But that's the overview. Let's look at all the stuff, okay? The oral cavity, the mouth, really, that's where we all start. There's two distinct regions. It's just this region right here is just a vestibule, space between the gums and the lips, and then the oral cavity proper. And really that's where we're going to be, thinking of and talking about. We have buccinator muscles within the cheeks here. We have the roof of the mouth. We have the hard palate. We have the soft palate in the posterior 1/3, just muscular. Get the hard palate from the maxilla, separating that from the nasal cavity. So there you go. There it is. And in the back of the oral cavity, we have the uvula, and that helps to just close off the nasopharynx, so food and water do not get up in your nose. We have some palatine tonsils within here as well, and again, those are lymphatic structures, and tonsils are tonsils. Okay, palatine are just the specific ones found in the oral cavity. We mentioned them way back, 2 weeks ago when we talked about lymphatic system. So here is that little, as you can kind of see, the vestibule and the oral cavity there. There's a whole bunch of stuff that goes on there, but we don't really need to get into all of that nonsense. We have the tongue that resides within the oral cavity, pretty obvious. There's your palatine tonsils over there on the side, and I'll just highlight it right there. Okay. There's the hard, there's the soft palate. Oh, excuse me. We have the tongue. Down along the bottom, we have some lingual tonsils. So we have the palatine. Excuse me. We have some lingual tonsils down along the bottom here. We have the lingual frenulum. It's this little flap of tissue right here. Helps to hold the tongue down. And it's the right size. If this is too short, then the tongue won't be able to come up, and the tongue won't be able to curlicue around the nipple, and the baby won't be able to feed properly. So I'll go in and just slice it, snip it, help to elongate that nonsense. Some functions of the tongue: taste, helps to manipulate the food, keeps it squished in between your teeth so it doesn't escape. It's also involved with the swallowing process, as it helps to push that bolus of food back towards the pharynx, and obviously speech. It is stratified squamous epithelium here, non-keratinized stratified squamous epithelium. Okay. There's some portions that may be keratinized. Don't worry about that. All right. For all intents and purposes, the vast majority of this thing is non-keratinized. A lot of abrasion goes on there, so I hope that makes sense. Oops. We have a number of salivary glands. Here's the parotid salivary gland. Sits just right here over top of that masseter muscle. We have the submandibular right here. And we have the sublingual right there, submandibular, and there's the mandible that's been cut away. And there you can palpate and feel that sucker right there. And then the sublingual is underneath the tongue within the soft tissue. Collectively, these three dudes produce saliva. There's some semantics on the specifics and the amounts that each secretes. Again, we don't need to get into all of that specificity. The parotid gland, that's the biggest one, and surprisingly, it doesn't even produce the vast majority of the saliva. It's technically the submandibular, but again, you don't need to worry about that. So where is it? Again, it sits just anterior, on the anterior and inferior to the ear, pretty straightforward. It has a parotid duct, and that actually empties out near the second molar, and that's kind of significant. If you've ever been to the dentist, which most of you probably have, you may ask yourself, at least I do, why do the dental hygienists always seem to kind of pick around some molars up there, around that second molar? Well, that's where the parotid gland duct empties out onto. And there's always a little extra buildup just because there's always a little extra secretion going on right there. So that is actually why that dental hygienist is picking on you back there a little bit more. We have also, if you have mumps, this is where the virus likes to get into, okay? Blocks that duct and you get a big old swelling on the side of your face there. The next one we have is the submandibular, and it's inferior and medial to the, again, medial, inferior to that mandible. Its ducts open onto the floor of the cavity. And I think they show them over here. Yeah, there you go. There's the submandibular ducts, and then the sublingual ducts are right here. So spoiler alert. Okay, it is also on the floor. The difference between a submandibular and sublingual is along the lingual frenulum. Okay, along that lingual frenulum down there. Submandibular is kind of towards the front aspect of the oral cavity, and it's underneath the tongue. I feel like goes without saying. There is saliva. I won't ask how much you produce. There you can see it. I won't necessarily ask how much you are producing ever. Most of it's produced during mealtime or when you think about food or you hear food getting made, which I guess is around mealtime technically. But if you start thinking about food, you can get a response of production of saliva as well. So it is psychological. There are things within saliva, and that's what I would like you to know. There is a little bit of mucus, kind of helps congeal this food together and form a bolus. There is some lysozyme. Lysozyme is a kind of antibacterial type of secretion. And then there's salivary amylase. And salivary amylase is important to know and important to remember because it helps with the breakdown of carbohydrates. Starch, okay, specifically. But functions of saliva, it helps to moisten the ingested food, helps to form that bolus. It's a medium through which food molecules can dissolve into and trigger taste receptors. Again, lysozymes have the antibacterial type of secretions with it. So, excuse me. So, there you go. Really, digestion begins here in the mouth. Again, I hope you understand this is where you put your food. So, obviously, this is where digestion is going to begin, and it's both mechanically and chemically that it begins here with salivary amylase. But mechanical digestion is an obvious function that occurs here. Again, we have a number of teeth. These teeth are involved with mechanically breaking down that food. If we mechanically break down food, it's all about increasing surface area for these digestive enzymes within the mouth and in parts as we go further on. Coordinated by, okay, there's a chewing center within the brainstem. So, yeah. There's a little bit of absorption that can occur along the tongue. Sublingual absorption of nutrients. So let's go on. Teeth. There are some parts and pieces when it comes to the anatomy of a tooth that you should know. There are 3 regions associated with a tooth. Collectively, teeth are referred to as dentition, but I don't know if that's really important unless you want to be a dentist. We have the crown. The crown is what is exposed, the part that's above the gum line. We have the neck. This is the portion at the gum line. And we have the roots. And the roots are down within the bony anatomy, within that gomphosis joint. Oh my gosh, did we say something from the past? Hell yeah, we did. Gomphosis joint. Synarthrotic. Okay. Here's those periodontal ligaments right here. All these little white look like bones. They're ligaments. And they help to hold those in place. Hold those teeth in place. So those are the 3 regions. What about all the parts and pieces? Well, these are some of the major ones here. We have the enamel. We'll just start there. We'll start at the top and work our way down. The enamel. This is on the crown. So this is the outer part here. There it is. That's what you brush every day. You can see it's calcium phosphate crystals, whatever. Underneath that, though, is dentin. And this is kind of the bulk mass of the tooth. Excuse me. Just as hard as bone. We have what's called the pulp cavity. It's the center of the tooth. And as you can see, it has some weird things in there. What are those weird things? Artery, vein, and nerve are within that pulp cavity. How do they get there? Through a hole in the bottom of the root, right down here. And that's called the apical foramen. There it is. I'm not going to write it. Apical foramen. Okay. That's how these nerves, blood vessels get up in the tooth. From the pulp cavity, we extend down through what's called the root canal. And again, that's what's bringing up, that's the pathway through which arteries, veins, and nerves are getting up into that pulp cavity. The last major part here is the cementum, and that's what helps to seal it down in the root. Ta-da! There you go. Do you need nerves? Technically, I mean, you don't really need nerves aren't necessarily a huge need for the function of the teeth. So, when you have a root canal, they get in there and they root out all those nerves, blood vessels, all that stuff, and get rid of it. So you're like, well, wouldn't that be necessary? Well, in terms of functionality, no, because what's the nerve going to tell you that the tongue or the inside of the mucosa of the oral cavity not tell you in terms of hot or cold? So not really needed for the function that is just the mechanical mashing of food. When we look at teeth, we have a multitude of different types of teeth, incisors, canines, premolars, molars, all that fun stuff, right? But we have different types of teeth depending upon how old you are. For the first several years of life, you have your deciduous teeth, milk teeth, baby teeth, some other names for them probably you know of. I'm not going to ask you when they erupt, but it's kind of interesting. So, some children can have their teeth start to erupt and emerge as early as 5 months, I've seen. So these are just averages. But, 7 to 9 months, 9 to 11 months, I mean, this is this is when your life's going to suck for a while. When it comes to permanent teeth, which are on the next slide, there are 32 of those. Those are the adult teeth. your last set of molars come in around in your late 20s, and these are your wisdom teeth. Hopefully they come in. If they don't come in properly, they can be coming impacted and whatnot, coming at different angles. There's various different types of impaction that can occur with those wisdom teeth, and you just get them removed. Just get them removed. How do you know when you need your wisdom teeth removed? You're going to have massive headaches every morning. Your teeth will bleed, or your gums will bleed excessively, especially when you are brushing your teeth. So here's the adult teeth right here. We have several different types of teeth. You're identifying them in lab. Should probably have a kind of an understanding of what they do, I guess, in lecture. Incisors, you have central incisors right there, your first two teeth, and then the teeth right next to them are your lateral incisors. So these are both incisors. Whether they're central or lateral doesn't matter. They're there to slice up food. Okay. Canines have a nice sharp point to them. They're there for puncturing and tearing up food. Easy. We have premolars and molars, and they both do pretty much the same thing. They grind up and they crush. Okay? They grind up and they crush. There's your 3 molars, a couple premolars, canine, and 2 incisors. Okay? So if you break it down to each quadrant, kind of the side, okay, right here. 2, 1, 2, and as many as 3. Some people just have 2. Again, all of these teeth are anchored within the gums in that alveolar socket of the maxilla and the mandible, and the gingiva is the gums. Once you chew up this food, you manipulate it, turn it into what's called a bolus, and the tongue pushes that thing back towards the pharynx. We just saw the pharynx in the respiratory system, so it's the same basic thing. I don't think I'm going to get into it again, but it's the same naso, oro, and laryngopharynx. Do we care about the nasopharynx? Of course not. You don't swallow food through your nose. So you got the oropharynx and laryngopharynx, and then to the esophagus. We have some muscles here, some pharyngeal constrictors. They are what's helping to constrict and push that bolus of food down towards the esophagus. Stratified squamous epithelium again, but that you already know. You don't need to worry about that. The pharynx is just there to get that food, to get that bolus from the mouth or oral cavity to the esophagus. What is the esophagus? It's found right behind the trachea. We saw that when we looked at the lungs. It's a collapsible tube. Okay? It doesn't have to stay open. It doesn't have to remain open at all. So it can collapse. And it obviously expands as food enters into it. There it is, posterior to the trachea. This begins right at the level of the cricoid. Remember, the cricoid was the most inferior line or demarcation for the larynx. And this is pretty much where the laryngopharynx ends and the esophagus begins. There's the esophagus. The esophagus travels down through the remainder of the neck there and through the thoracic region, piercing through the diaphragm and dumping into the stomach. Stomach's in the abdominal region. Pharynx is what is the line of demarcation between the thoracic region and the abdominal region. It penetrates through the diaphragm, through an opening called the esophageal hiatus. Okay. And if portions of the stomach come back up through that esophageal hiatus, it'll rub the diaphragm, causing hiccups and causing some regurgitation of the digestive juices of the stomach back into the esophagus. Heartburn. We have a number of constrictor muscles that are involved with helping to constrict the pharynx to get the food down into the esophagus. We also have a couple of sphincters as well that need to open up. Sphincters are going to be awesome. Sphincters are what govern the entrance and exit of food stuff as it travels through the GI tract. Here are our first two sphincters. We have a superior esophageal sphincter right there and an inferior esophageal sphincter. You don't know it as an inferior esophageal sphincter. And we truly never really talk about the superior esophageal sphincter, to be frank. But it closes. We always talk about just the epiglottis. The epiglottis is what flaps over, to close off the trachea to get food and water to go down towards the esophagus. The superior esophageal sphincter also has to relax and open up. It constricts when you breathe, so it prevents air from excessively getting down into the stomach. But we all know about the inferior esophageal sphincter. That's your cardiac sphincter. Just put SPH for sphincter. That's the cardiac sphincter. That's the one that is associated with the stomach, helps to open up and get contents into the stomach. They're a circular ring of muscle. I don't really know what else to say about it. When we look at the histology of the esophagus, it's shocking, non-keratinized stratified squamous epithelium. Again, high abrasive, helps to protect. We have some elastic tissue that's a little bit more prominent, which allows this big thing or this long tube to expand. We have 2 layers of skeletal muscle, so nothing different there. These help to ensure that it kind of moves down. The only thing that is a little different from terms of muscle standpoint, I guess I could say, is the upper third of the esophagus is skeletal muscle. The middle third is kind of a mix between skeletal and smooth. And then the inferior third of the esophagus is all smooth muscle. So in that kind of middle to bottom, middle third and bottom third, you can't do anything with it basically. In the upper third of it, you can wheel yourself to constrict the esophagus to help heave-ho it out. So there is that, which can be a survival mechanism, to be honest. That's really the significance. Otherwise, it's just all reflexive. I mean, you don't sit there, go, okay, upper esophageal, contract. You don't do that. It's all reflexive, but it is skeletal in the upper third, and that's more of a survival mechanism in case you swallow something that you shouldn't have. When it comes to the actual swallowing process itself, there are 3 phases associated with it. It's a oral phase or a buccal phase. Okay, buccal phase. This is really the only one that's voluntary. I mean, you decide to put stuff in your mouth, usually. You decide to chomp it down and chew it, and you decide to swallow it. So the buccal phase of swallowing or deglutination, that's the buccal phase. That's the first phase, and it's always voluntary. The last 2 are involuntary. You have from the mouth to the pharynx. So we have a pharyngeal phase. Again, involuntary. Constrictors constrict and push that bolus of food down towards the esophagus. The last phase is the esophageal phase. Again, involuntary for the most part. You don't think of doing it unless you've done something stupid and swallowed some poison. Medulla oblongata is what stimulates it. That's, we had the mastication center earlier. We have a deglutination center as well. I mean, the brainstem does all your rudimentary stuff, right? So it makes sense. I'm not going to get into the mechanisms involved with triggering that. It engages so much stuff that we didn't talk about muscular-wise. We don't need to get into it. As you can see up here, this does a great job of showing you the voluntary phase, the buccal phase right here. As you mashed up that food into a bolus, see the tongue helps to kind of push that back towards the pharynx here. As it enters the pharynx, it actually triggers different receptors in there that helps to get the epiglottis to close over that glottal opening. And then the pharyngeal constrictors will contract and help to push this bolus of food down towards the esophagus. We get elevation of the soft palate, contraction of the pharyngeal constrictors, and this ensures that it goes down. Then as this bolus of food gets down closer to the larynx here, you can get elevation of the larynx from all those extrinsic muscles that we made reference to when we talked about the larynx in the respiratory system. That helps to raise it up, which helps us to open up that superior esophageal sphincter. And then through peristalsis, we rhythmically move this thing down towards the stomach. As it approaches the stomach, it'll trigger the cardiac sphincter to relax and open up, and now it oozes on into the stomach. And that's the basicness of deglutition or swallowing. I'm not going to ask it as a short answer question. It would only be as a multiple choice type question. And there's hiatal hernia. Again, if a portion of that stomach kind of comes up through, and this is where the diaphragm will be, guys. So if a portion of the stomach kind of comes up in here and pushes up through that esophageal hiatus, it can cause hiccuping, and it can cause heartburn as we get that acidic juice coming back up from the stomach into the esophagus. It's not designed for that. Okay, we have goblet cells that produce mucus. That's it. We don't have any specialized cells in the esophagus that buffer the acidic content that would happen, to come from the stomach. So that does not exist. That exists in the duodenum, but not here. Okay. There's different stuff that you can do. Change your diet, change how much you eat at a sitting. Don't lay down after you eat. There's a technique too where you can kind of stroke down just right underneath the xiphoid process, just a little bit lower to that. And if you just do a stroke down, you can get that stomach to relax a little bit and come back to where it's supposed to be. If you don't want to do that, you can take proton pump inhibitors. You can take histamine blockers. This will diminish the acid production within the stomach. But if you do that, then I guess if you have chronic heartburn, chronic reflux esophagitis is the fancy word for it. If you have chronic reflux esophagitis, then you'll do anything. But if you reduce the acidity of the stomach too much, then you won't be able to digest or break down amino acids. So there is some consequences of that.